Perfect. Thanks for the introduction, Jim, as always, and thanks everyone for joining us today. This is a really exciting topic, at least for me, talking about porcelain laminate veneers, as I think this is the go-to restoration for patients that are actually looking to enhance their smile uh, with longevity, but also be conscious and aware about maintaining healthy tooth structure. So we will try to cover important aspects both from the clinical work and the laboratory side as well. So during the last 9 years, I've been working here at the University of Pennsylvania School of Dental Medicine, and during the last 5 years, serving as the clinical CAD/CAM director. And one of the materials that we use is the VITA Trilux Forte block, which is a Feldspathic porcelain block fabricated by VITA Fabric. And as any other material, it has its indications, right? And it has maybe some other situations that we might want to use another material. But what we see now is an excess of concern about using glass ceramics, which shouldn't be, because these type of materials have been out there in the market for many, many years. And a substantial amount of evidence shows us that if we understand how to use it, when to use it, and how to apply all the confirmed protocols, it's extremely successful. Okay, so what I've been trying to do during these years with my mentor, Professor Marcus Blatz, is actually always be aware of the literature out there and always try to put together review papers that can help our students and colleagues on understanding what we know about each of the materials and where we think that this works safer. For us, it's about reducing remakes and making the patient experience, while being beneficial on the aesthetic side, being safe as well, right? Being with a high clinical success rate. So that's what we try to emphasize on our publications, and I want to try to summarize this during the next hour. I started in 2010 as a CEREC user back in Costa Rica when I was full time in private practice. And I enjoy the workflow to do veneers with the VITA blocks as a chairside dentist. And now what we have been working and how these have been evolved due to the possibilities of connectivity and so on is the Connect workflow, right? Where I can do my clinical work and scan and send this out to an external lab who will take over on the design and fabrication. And also I want to show you guys as well at the end a mixed workflow where I have a third-party lab or another lab to do the design, but with my equipment and with my, knowledge, basic to moderate knowledge on staining and glazing, I can finish the case without needing to design the entire restoration myself. So it's very exciting to have different options within your workflow. So today I'm talking feldspathic veneers. Feldspathic porcelain need to be adhesively bonded. And we know that the bonding side has always two interfaces. One is the ceramic side, and the other one is the tooth side. So for us, it's extremely important always to think about preserving as much enamel as possible. Many times we over prep, we are in deep dentin, and the bond strength on the long term will always be less than if we're bonding to fresh cut enamel. So that's why we use our CAD/CAM burr block with Brasseler that has the 0.3 millimeter depth cutting burr that will help us provide an enamel guided preparation design. We also know that for milled restorations, we want to have smooth transitions. We want to have a very minimal chamfer to understand where to mark the margin of the restoration and where should it seal. And that's some of the features that you can find in our CAD/CAM burr block. Now, when we talk about laminate veneers, we're working on the aesthetic zone. Tissue management is the key. No matter how great your ceramist is, right? If your papillas are lost, if your tissues are inflamed, or there are recessions after cementation, the case is not a winner. So also we provide a lot of time and emphasis on using the thinnest retraction cord possible, which is the 000 retraction cord, and also using rounded and smooth retraction cord instruments, right? Instruments to pack the cord. So our ideal point of setting the margin on the aesthetic zone is at the gum level with the 000 cord placed. That gives us the possibility to hide the tooth that might be slightly discolored, but not violate the biological width without causing inflammation or recessions later. Okay, this is also a very nice instrument that I always like. I think I mentioned it during the last webinar. It's kind of a shield to protect the gingiva while I'm finishing my margin, ideally with my 4x magnification loops or under microscope. And this is something that we are emphasizing more and more, making sure that our students and residents learn how to use a microscope, because now in the software you can zoom in thousands of times, and we want to match up what we can do in the clinic as well. So that's why for us magnification, proper instrumentation are pretty much the basis or the foundation to be able to have long-term clinical success. So here we show that using a fine grit diamond burr, if you're using a milling machine that will cut the porcelain, the feldspathic porcelain or the hybrid ceramic porcelain materials are the ones that give you the best marginal adaptation. You want to match your granulometry of your diamonds that you use in the patient's mouth, prepping the teeth for the veneers, and having the same within your milling machine to cut the ceramic material. So this is a short video, and here you can see a little bit of what I'm talking. It is very important to pack the 000 retraction cord perfectly without having any excess, refine at that gum level. Then you pack the second cord, which usually I use the 00 cord that I will remove, and immediately after removing, I'm going to be drying immediately and then going in with the scanner. This is the CEREC Prime Scan that I'm using on this video. And that way you can capture a really nice digital impression, because that's the foundation for the next step. That would be the design and elaboration of the final restoration. So when we are talking about laminate veneers, we have different options. We have blocks that are monochromatic, which I don't use on a regular basis for the aesthetic zone. There are blocks that are polychromatic, like VITA Trialux Forte, which I use a lot in the aesthetic zone because they already have that degradation between the 3/3 of the tooth. And depending on the amount of veneers, just with a multichromatic block, it's sufficient for the aesthetics. But when I have cases that require fewer number of restorations, the more detailed the characterization needs to be in order to match that, whether it's that single central or the centrals and laterals to the adjacent and opposing dentition. So shade selection is key. What I always suggest to do for these type of aesthetic cases is to take the shade guide photos at the beginning of the appointment to avoid dehydration. Always check the value by turning your photo in black and white, and then add as much saturation as you can so you can actually see more clearly the internal characterizations that you're trying to resemble with your ceramic veneer. So here you can see it's the same image that I took, this one on the right. I just turn it black and white. This is on my phone, or add all the saturation that I can. And when I'm doing the staining and glazing or characterization, we have that information. I think that a very good laboratory technician will always like to receive this information from the clinician, because it will make their life much easier as well. So the communication of color between the clinician and the dental technician, if you're not doing the entire laboratory yourself, plays a very important role. Whenever I'm a little uncertain about what block to use, what is the exact color, I also like to rely on technology. This is the VITA Easy Shade Advanced, which is nice because you can download the Mobile Assist app and then you can put together both things, the reading from the spectrophotometer and your intraoral photo. So this information is what I like to share to the lab technician whenever I have challenging cases on the aesthetic zone that shade matching could be a big problem. Okay, so those are pretty much the foundational concepts for us to go into the clinic. So now we're going to start talking about the material for today's webinar, which is a silicate ceramic. It's the traditional feldspathic ceramic. And this is actually the first block used for the first inlay made with the CEREC system back in the 80s in the University of Zurich. So this is why Jim was saying, while many things are new, many or some things might not be that new. So this material has been out in the market for many, many years. Later came the multichromatic version, which is the Trelux Forte version. That's the one that we use. So we know that feldspathic ceramics, in comparison to lithium disilicates or zirconia, have a lower flexural strength. But we know that when we bond it properly, it gets reinforced and it is sufficient for working successfully on the long term in the aesthetic aspect. So our preference to use VITA Trilux Forte blocks are for porcelain laminate veneers. So today I prepared 3 cases that I want to review the details of the clinical and laboratory steps so you can see how we implement this specific material. So when we receive patients that are coming with the chief complaint of not happy with their smile, not confident with the aesthetics of their teeth, everything should always start facially driven. So we will start with a set of portrait photographies, very straight images, thinking as making a nice x-ray that you don't want to have overlap, you don't want to have one side bigger than the other, you want to have a very straight image, and we want to evaluate the lip dynamics and the height of the lip on a maximum smile, like the gummy smile that you see on the right, because that will dictate other possible needed therapies like crown lengthening or like soft tissue grafting, if that would be the case of a very high smile. In this case, we have an average medium to high smile. We don't need to be that concerned about any minor soft tissue differences at the cervical margin, but it's pretty much the clinical crown that needs to be considered to have something that looks much better. So here you can see that there has been some failed restorations made out of direct composites on the incisal edges that have chipped. The differences of ceramics compared to composites is that composites do get stained, right? And you can see that as well. There's minor diastemas, and the angulation of the teeth, as you see in number 10, is very different than number 7. So those are, in a very brief description, some of the findings after the set of intraoral photographs and intraoral scans. So now here, what I'm doing is using the Connect workflow. I'm taking this information, the extraoral photos, the intraoral photos, and the intraoral scans, putting this on a safe folder and sending this out to a very good laboratory technician, and take the advantage of the use of what we call the Connect workflow. So in this case, for example, I put everything together and send this out to Sergio Lozas, who is a certified dental technician down in Argentina. And once he receives the folder of the information that I gathered, then he starts working on creating a digital wax-up. The key aspects for the digital wax-up for us, facially driven. I already explained that with the portrait photos. Understand where would we like to set the incisal edge position is extremely important as well. So with that, we can evaluate the ratios of length and width of the maxillary central incisors. Once the centrals have been designed ideally, then we start moving distally. We want to make sure that these digital wax-ups follow the smile line, which is dictated by the lower lip, in order to have an ideal buccal corridor. So here, Sergio does this digital wax-up in his Exocad software, and then he sends me the STL file, and I can do the 3D printing here in-house. So it's a very nice combination. So when you're doing 3D printed of your models, you gotta be very picky. You wanna make sure that they are always printed at a high resolution and that you are very detailed on the cleaning and curing and the post-processing to avoid imperfections. We like to use a rack wheel and a low-speed motor to do manual polishing of the external surface of the 3D printed model before we make the silicone matrices for the mock-up or provisionals or preparation guides. That way, what we transfer into the patient's mouth is something more accurate and more detailed as well. So here you can see a very nice potty matrix that we like to do, not only with the PVS heavy body, but also with light body to reline it. So we copy all the details and we will place these in the mouth of the patient as a mock-up. And once the patient has approved that, then we can use it as a prep guide. We can prep through the mock-up with our depth cutting burrs, and then these are the 4 burrs from our kit that we indicate for porcelain laminate veneers. So here, what I do is make all the preparations for the 8 laminate veneers from maxillary first bicuspid to maxillary first bicuspid. And then I'm going to be very critical of my preps while the patient is in the chair. I'm going to check that all the margins are clear, that I have proper extension of the preparations in order to avoid black triangles. And once I feel that the quality of the image I obtained was good, then I will be sending this out to Sergio in this case, to the laboratory technician, and then we will schedule a Zoom call. And actually this recording was through one of our meetings where we discuss where are the margins, where are the limits of the veneers, and where could be tricky areas that could bring as a consequence, if not considered properly, a black triangle or irregular orientation of the design of the final restoration. So yeah, we meet online, but we evaluate all this so he can move forward and finish the design of these laminate veneers. So as I said, the material of choice for these cases is the VITA Trilux Forte, and what we do is always to work with this material as it is a multichromatic material. You can buy the same monochromatic material called VITA Mark II, which we honestly don't use anymore. We only use the VITA Trilux Forte, which is multichromatic. Feldspathic porcelains, as we know, are still the most translucent material, but they must be adhesively bonded. And as I said, it's an advantage when you have already that certain diffumination of the translucency levels within the block. You can buy them in different sizes of blocks, 12 or 14. And then here, Sergio starts doing the milling. He has a 5-axis milling machine, and you can see here the final milling outcomes. You can see the sprues are there. So we like to use feldspathic porcelain for blocks for laminate veneers and for anterior crowns when we have an ideal abutment color and we have a restoration thickness of 1.0 millimeters. We don't like to use feldspathics on endo-treated teeth or teeth with severe discolorations, as the material is too translucent, and in certain situations we might not have the ideal final result concerning the aesthetics. Now here, after Sergio has milled that, he's also 3D printing another model, which is the model of the preparations that I sent him. And this has to be also printed at a high level of accuracy and a very strict cleaning and curing. So he can use this to set the veneers in and start evaluate the aesthetic of the integration of all of these veneers. So here he will check the interdental embrasures, the position of the line angles, the position of the incisal angles, the symmetry with the contralateral side, and making sure that this starts to look aesthetic as a whole unit, right? Not only one restoration at a time. So having a high precision 3D printed model of the preparations in this workflow, I think it's very beneficial for the ceramist to do their magic, right? Here, he's going to be working with a monolithic restoration design, but he will always put his artistry on the surface and the final design, followed by the staining and glazing. So here, what he does is an external staining and glazing, and then he sends me the restorations, which I receive a few days later, and I'm ready to go for the aesthetic try-in. So what I do when I'm doing the try-in, I'm going to remove the provisionals very carefully. I'm going to clean the abutment teeth with some pumice and a brush in low speed, very gentle with the gums. I might use a syringe with chlorhexidine and try to clean the tissues as well. And then I'm going to start using a trying resin cement. Once I've tried in the fit of each of the veneers individually, and I've tried the veneers with their adjacent restoration for evaluation of the interproximal contact points. So my go-to color always for the aesthetic try-in, it's a clear aesthetic try-in resin cement. Remember that an aesthetic try-in paste is a fake cement, right? That we will never polymerize, but it will give you the same color appearance that the final restoration. So here the trick is to use your try-in paste, remove the excess with a micro brush once you've seen all the veneers, and take photographs, take intraoral and extraoral photographs, and then I export that immediately to my PC, and then I sit for a few minutes and check that on the computer, because just in the dental chair, I'm not able to see that level of detail as if I see the images. So here I'm using the Panavia V5 clear trying paste, which I will just inject on the intaglio surface of the veneer. And then this gives the patient a better first impression because the veneers are not falling around, and the patient can sit up straight and evaluate in different angles. So the use of a trying paste, we think it is extremely important. Now, after accepting the aesthetics of the veneers, we now need to focus on the adhesive protocols, right? So it is important to have a specific container to have the veneers in order on which position they should be, and your preferred resin cement system. In our clinics, we use the Panavia system from Carrara Noritake, and now they have the Panavia Veneer LC, which we like it a lot because it's a light curing resin cement only, and the advantage is that it gives you much more working time. It comes with the phosphoric acid to etch the enamel, the bonding, which would be the universal bond quick, that you don't have to light cure as well. So you are not concerned about leaving a very thick layer of adhesive that might compromise the final seating of your feldspathic porcelain veneer. So these are very important aspects to keep in mind. And then it comes with the Clearfield Ceramic Primer Plus, which in this case will act as your traditional silane coupling agent. The only thing you need to add here would be the hydrofluoric acid that you will apply on the intaglio surface of the laminate veneer for 1 minute to etch properly the surface, then wash and dry very well, and then we apply the silane coupling agent. We just let it evaporize, and then we're ready to load the veneer with the light curing resin cement system. So this is pretty much the step-by-step of how to treat the VITA Trilux Forte blocks before, or restorations made out of these blocks before the adhesive cementation technique. But remember, as I started saying, every laminate veneer has two surfaces of adhesion, right? One towards the ceramic side and the other one towards the tooth side. And many times you might have expected a debonding of a veneer or a fracture of a veneer, and maybe the lack of bond strength came to the tooth side and not to the ceramic. So how do we treat the tooth? We like to use the AquaCare, which is a unit for intraoral air abrasion with water that can help us clean very well the abutment teeth after removing the provisional restoration. So now you can see a nice and clean surface. And once we do this, which takes us just a few minutes, then we will use the phosphoric acid, as we're pretty much 100% of the prep on enamel. We'll apply the phosphoric acid for 20 seconds, wash and dry for the same period of time to avoid having excess of acid on the tool surface and cause sensitivity. And once we do that, then we are able to dry the tool surface properly and apply your bonding agent. So here for me, this is a key aspect for cementing veneers. We want to use a self-cured bonding agent here. I don't need to light cure this bonding agent, so I can air thin it and I don't have any risk of leaving too thick of a layer of the bonding agent compromising the seating of the veneer. So here are the feldspathic porcelain veneers being cemented. I like to use cement two at the same time, the two centrals, to assure that they are seated perfectly with symmetry, and then make sure that your curing lamp has been calibrated, that you place it close enough on both surfaces to fully cure the resin cement. Remember, there is no chemical activation of this cement. This relies on the curing. So how we approach the light, it is a very important factor to consider as well. And here you can see a really nice aesthetic outcome. These veneers made by Sergio, I think, look amazing because they are monolithic. The advantage that I see with monolithic is that they are less brittle, less chances of chipping, that if you place the ceramic inside the furnace for 6 or 7 times, but also with the use of the multi-chromatic blocks plus the VITA Accent Plus kit, which is the one for staining and glazing, I think that we can obtain a very natural characterization and diffusion of the chroma between the cervical part and the incisal edge as well. So whenever you have cases of multiple restorations, I always go for monolithic with this combination, Vita Trilux Forte and some Accent Plus to characterize at a higher level. And here you can see very confident patient now, very happy with his new smile design. Now, where is another scenario that I like to use feldspathic porcelains? Well, also in the aesthetic zone, in cases of minimal invasive dentistry, right? And this patient, she's actually a colleague of mine, and she was concerned about the wear of her anterior maxillary teeth that you can see in the incisal edges, the rotation on number 10, but also the wear on the palatal surface due to some acid reflux from the stomach, right? So whenever we have these cases, I try to do additive dentistry. I don't want to pretty much cut out more tooth structure. I want to be able to cover and protect that dentin that has been attacked by the acids. In the lower arch, her concerns were the diastemas as well, and also you can see some thinning of the incisal edges and proximal surfaces as well. So I think these cases are really well indicated for feldspathic porcelain laminate veneers. Shade selection, as I said, always at the beginning of the appointment before we have any dehydration, and a clean documentation will always facilitate the finishing of these types of restoration. So here we go for the VITA A1. You can use both the 3D Master or the Classic Shade Guide. The blocks come in both different types of color. As I said, I like always to confirm with the use of spectrophotometer, and this one is the latest one from VITA called the Easy Shade Light. It is very easy to work with. It's a very practical unit. Is much more affordable as well. It will just give you the color on both VITA Classic and 3D Master. This one has non-connectivity through the app, as I showed you in the first case, but actually it's a very practical unit. Jim sent us one a few months ago for a clinical study that we are doing, a research study, I'm sorry, and we've been using it, and it's also a very practical tool to have. So whether you like the VITA Easy Shade Advanced or the Light, it's something that I use on a regular basis. So here, same workflow. I send all this information to Sergio back to Argentina, and then he starts doing his diagnostic digital wax-up that he's going to send me back the STL file, and I can 3D print here that model, and then I'm ready to make a mock-up. I'm ready to evaluate the aesthetics of the digital wax-up. And many times we see some irregularities. And here, if I'm critical, I see that the incisal edge of the lateral, one is different than the other. So we make those modifications. Once we have the 3D printed model, it's better to see the aesthetics when you have the printed object. Sometimes in the screen it's a little challenging actually, right? Because we're working on a flat screen. So we evaluate the printed model, we make some modifications, we polish the surface, and then that's when we go and make the putty matrix. So all these small details, if you skip them, you're going to get not close to your final outcome. But if you consider all these details, you're adding to the quality that you can achieve on your final restorations. So here I can prep through the mock-up. As you can see here, I place some bisacryl material over the teeth, right? And then I use our depth cutting bird. The nice thing, as I said, it's only 0.3 millimeter thick, the depth cutter side, the wheel side. Why? Because the thickness of the enamel on the cervical third of incisors, it is very reduced. So we don't want to use a depth cutter that might be more than that, because we could end in certain areas on dentin and not on enamel. So with a pencil, I just make a line through the depth cuts, and then with a red line fine diamond burr, I will just prep the 3 planes, making sure that I get rid of those lines. And then with a perioscaler, I will remove what is left from the mock-up. And after that, I will finish my prep by creating the chamfer around the cervical margins and involving the incisal edge. So here, it's the last step on the preparations, which once I've removed the mock-up, what is left from the mock-up or the prep guide, right? Here I have also these prep guides made from putty from my modified and polished 3D printed model. So here it's all about space distribution, right? Whenever I'm working on these minimal invasive cases, you want to make sure that you are consistent. You want to work at 0.3 millimeters, 0.4, 0.5, whatever you need, but you want to be consistent. You don't want to have one area where I have 1.5 millimeters of space and then one area that I have 0.3, because those differences are going to actually affect the final shade of the restoration as well. This is a material that has a high glass matrix, so you want to be as homogeneous as possible. Here in the palatal side, we're going to do palatal veneer. So this is pretty much like a sandwich technique. We're going to have a facial veneer and a palatal veneer, and that way we don't need to create a path of insertion for these teeth if I would be prepping a crown, right? So those are the advantages of being less invasive. Is this easier than prepping a crown? No, of course not, right? This requires much more detail, but it's something that I think we can all do. So you can see here the final preparations on both the upper and lower incisors. And here the take-home message is that you want to have preparations that flow. You want to have smooth transitions. You don't want to have sharp line angles. And whenever you have a wide diameter, for me a wide diameter is a wide diastema, sorry, a diastema wider than 1 millimeter, I want to wrap around the interproximal surface with the veneer. That's the only way that you can actually push the tissue properly to end up with a nice scallop papilla and avoid the black triangles. So those are important things to consider. Now here, this is part of Sergio's work back in Argentina. He has printed the models from my final digital impressions. And here in the software, he actually makes some Geller dies. These are 3D printed, but the nice thing is that that can give him the ability to evaluate the fit of the palatal veneer and the facial veneer at the same time, which is something challenging, right? So here you can see how nice these final veneers look. These are Bilaminar veneers, a buccal and palatal veneer. Can I have simplified myself and just cut more tooth structure? Yes, I could, but when you're treating dentists, they know better, right? They know about the importance of maintaining as much healthy tooth structure as you can. So I think this is a very valuable treatment modality. Here are the feldspathic veneers after staining and glazing with the VITA Accent Plus and seated on the 3D printed model. So now I received these after a few days of Sergio's working and shipping times, and then it's my time to go ahead and do the trying and do the adhesive cementation. So when you want to be less invasive, prep less, you need to have more time for cementation, right? If you schedule yourself half an hour to deliver a crown, I would schedule twice as much the time when I'm delivering this type of partial coverage restorations. And actually, I like to have the printed model and use these Optra sticks to practice the path of insertion of these veneers. This is the tricky part from the clinical therapy on how we can obtain the best positioning of this restoration. So the use of the rubber dam, it's extremely important. It's much safer to work with a rubber dam, more when you're cementing Bilaminar veneers. Some go from the facial side, some go from the palatal side, control the bleeding the best possible way. It's extremely important because this material, as I said, it's like a glass, but if it's well bonded, it's reinforced many times, and they have very good success rates. Whenever you want to use a self-curing, self-etching resin cement, no rubber dam, that's when you are jeopardizing the longevity of these types of restoration. So you can see here a very nice aesthetic outcome. This is a characterization, external staining that Sergio did, and you can see a very nice soft tissue outcome after a few days of cementation with no black triangles, with nice position of the cervical margins, with symmetry as well on both the incisal embrasures and cervical embrasures. Here you can see some lateral photos as well. And when we wrap around, as I said, whenever we have wider diastemas, you can see how nice we're able to close those spaces and avoid the black triangles. In the lower arch, we did pretty much the same. These are porcelain laminate veneers. These are just in the facial aspect, but as you can see how they wrap around. Their extension is on the facial, mesial, and distal areas, so we can support the tissues, support the papilla. In mandibular incisors, I basically don't do single crowns because they are very small teeth, they are very difficult to prep, and they are very difficult to keep vital when you prep them. What is the tricky side? The delivery, right? So in this case, we have preparation design that covers the incisal, facial, mesial, and distal. So the path of the draw, path of insertion is very specific. So we want to practice it as well. So the preparation design is very important to facilitate your path of insertion. So here we have a mixed horizontal and vertical path of insertion. Pretty much the restoration goes in at 45 degrees, inciso-apically and buccolingually, and that way we can have a nice adaptation with the soft tissues and a passive fit of these laminate veneers. And this is a very nice outcome of very small restorations. What you can see here with a macro lens, how nice this looks. Look at the position of the line angles, the interproximal surfaces of the design as well. I think those are the difficult things to do in the lab and in the clinic when you do the preparations. But I think that material-wise, both VITA Trilux Forte and the adhesive resin cement play a key role in order to give us the aesthetics that we want to achieve. So as I said, whenever you're working with less amount of restorations, the detail on shade communication and detailing of the restorations is much more important, right? When you're doing a full mouth and you're doing 28 restorations, you can just choose one color and everything will look the same. But in this type of cases, I think this is a modern dentistry. Shade understanding, communication plays a key role in order to be successful with this type of restorations. And now I would like to finish with this case, that this case pretty much tells me or teaches me that as a prosthodontist, I'm not able to solve all the cases by myself. Here, this patient had not an ideal distribution of the spaces, and the sizes of her teeth were not the best ones. So this patient is seen first in the orthodontics department, and they do a great job by aligning the teeth where we want. But before we decide to remove the brackets, I always like to see the patient just remove the wire and then make a scan. Once we make the scan in the software, we can remove virtually the brackets in the models, and then we can do a digital wax-up. And what is my idea? My idea is that these teeth end in the middle of the space that the final restoration is going to use. So whenever I don't have a proper mesiodistal position of the teeth, I like to work interdisciplinary with the ortho department, and now they can help me determine where I want the incisal edge position, where is my midline, and then make sure that we distribute the space properly. So these abutment teeth are going to end in the middle of the space that the final veneer is going to utilize. Okay, so mesiodistal corrections, we use ortho, and incisal cervical corrections or cervical corrections first, we work with perio. Some of us are okay doing certain type of gingivectomies. Whenever it's more of something needing to reduce more bone, we like to work with our periodontist colleagues so they can help us with that. But look how nice the virtual treatment planning here helps me decide exactly what we want to do, right? We're going to not only idealize the incisal edge position with the prosthetic part of the therapy, but also we're going to correct the position of the cervical margins to maintain a nice proportion of 80 to 85% width and length. So this is a totally interdisciplinary treatment plan that it's done first, and then once we have removed the brackets, I'm able to place the mock-up, right? So here I can still have another chance to see if this is what I like. Maybe I want to correct the canines in the mock-up. So I take these photos, I send these back. This case, the lab was made by Sean Han here in Phoenix, Arizona, but pretty much the same initial workflow, right? I collect the data, send it to him, we meet on Zoom, we work on the digital wax-up. Once I see that the teeth are placed in a good position based on the design, I send this patient to the orthodontist so they remove the brackets, and then I can make my mock-up. Once I have the mock-up, I still have chances to improve. As I said here, I want to improve the canines, mostly 11, and I document this, and we know for the final restorations where we want to make certain modifications. Here, I'm using our 887 KR burr from the Brasler preparation system, and very round and thin instruments to pack the core. This is the second core, the 00 that we will remove, and after that we will go in with the intraoral scanner after drying very well the surface and scanning the abutment teeth. Okay, the 000 retraction cord is always inside the sulcus, completely packed without any excess as well. And then it's my job now to evaluate my scans, be very critical, because that's the moment to do so. The patient is already there, the patient is anesthetized, and that's where we can make small corrections. So within the software of the scanner, when I'm using the CEREC, I have the preparation analysis tool. I always like to activate that feature and see if I have undercuts, if I have very sharp areas, if there's any area on the margin that it's not smooth for the software. And based on that information that I received, right there I go back and make the modifications and rescan it. So when I know that this is going out to Arizona for Sean or to Argentina for Sergio, I know that I've done this quality control myself. And I'm not saying that sometimes they tell me to, make modifications of my veneers or my preps, but this reduces that back and forth, which could be annoying in many situations, right? So here you can see the nice preps. And then I send Sean this STL file. And in this particular case, I still remember Sean telling me, I am very busy this week. I would need a little more time to finish the veneers. And we've been working together for many, many years. So that's something that we have, that those type of conversations, if you guys know what I'm talking about. And he says, well, you know what? I'm going to send you the STL of the restorations, and you can mill them and finish them yourself. That way, we can shorten the production time. So he sent us the designs. We just place the blocks on the milling machine, and I just mill these from the VITA Trilux Forte blocks. And then I have here my own staining and glazing kits, and I don't use more than 3 or 4 stains, to be honest. I like to print the model, as I mentioned. I like to sit the veneers, and I like to mark those line angles and try to confirm that I have symmetry. And once I do that, then I will apply some of the effect stains, like the ES13, the O2, and the 11. And with that, I can characterize the incisal and cervical thirds very gently. We have here one Vita furnace that it's very, very practical to use for these type of staining and finishing. And for the finishing, I always like the Vita Accent Plus. I think it has a thinner granulometry of the glaze, and it doesn't look so excessively shiny. So as I said, hydrofluoric acid for 60 seconds, wash and dry. We use the ceramic primer plus, which is a traditional silane coupling agent, but also it has MDP. So for whenever we're going to work with zirconia, we use the same product. I don't need to buy separate silanes or primers. Everything can be used with the ceramic primer plus, which is very advantageous. And here we go for the same cement, the Panavia Veneer LC. And as I said before, you got to make sure that you treat both surfaces properly, not only the ceramic side, but also the tooth side. Many times we received emails from colleagues, or Jim has received the same. I had a debonding of the veneer. I think the material doesn't bond well. Well, we got to be critic about the complication. Where was the cement? Was the cement sticking to the tooth, or was the cement sticking to the veneer? If you see cement in the intaglio surface of the veneer, that means that maybe you didn't treat the tooth as properly as it should have been treated. So in this case, we did a gingivectomy, as I mentioned, right? And these tissues are slightly immature. So whenever I'm delivering the final restorations, I try to avoid clamping the tooth that I'm going to be cementing the veneer. So I place clamps on the bicuspids here, and I use a modified technique of the rubber dam. But if I see that the tissue is stable and it hasn't gone through a surgery very soon, then I do place the clamp on each of the abutment teeth that I'm going to be working on. So I apply the adhesive. As I said, the Quick Bond Universal has the advantage that doesn't require to be light cured, so I don't have the risk of having a very thick layer of the bonding agent. So the veneer is not inserted with stress. You want your feldspathic porcelain veneers to always sit very passive on the abutment teeth. You want to place sufficient cement so you have a consistent flow of the excess of the cement that will assure you that you are sealing that margin around these restorations, right? So here I'm starting to remove excess. I'm trying to clean any excess in the interproximal. After this, I remove the 000 cord. I like to keep the 000 cord in place when I cement because it blocks out the sulcus. It doesn't let the excess of the bonding agent or the cement go deeper inside the sulcus. So with this, we see that the soft tissue conditions just a few days after are really nice and really helpful. So what we do, we pack the 000 cord just You wet it with water and you pack the cord. You do the etching and priming of the surface and the final cementation, and then you remove the retraction cords, and that way you are blocking any excess to go deep inside the sulcus. So this is designed by Sean, as I mentioned, milled and finished by me. Nothing crazy, right? Just a little bit of a stain and glaze, but I think we have a very nice final outcome. What is the take-home message? Many cases we are not able to solve them by ourselves as restorative dentists, right? Or as a lab technician, if you see that the position of the teeth is not the correct, the position of the gums is not letting you design something that is harmonious, something that has proper ratios of length and width and an ideal incisal edge position, then you can have this discussion with your clinician and say, I think here we need help from other specialties to help us treat these. So when I'm in the diagnostic part, whether I'm doing the digital wax-up or sending it out to one of the laboratory technicians I work with, I tell them, idealize the design it perfect. Don't adapt to the pathological situation. And with this ideal design, we will notice exactly what needs to be done prior for us to get that final outcome that we want. So I think this is something important. Nowadays, we think that all the cases are totally straightforward, and with the use of technology, we can solve everything. Yeah, big percent of the cases, but also many cases do need some pre-work, different treatment modalities, so we can have a less invasive option. Can I solve this case with ortho? Well, maybe yes, but I would need to prep more the teeth. Maybe I will end up in dentin, right? Because I'm prosthetically correcting malposition or misangulation of some of the abutment teeth. And then that also brings down the possible longevity of the restorations when compared to bonding 100% to enamel surface. So as a few conclusions, I would like to say that we want to invest in technology. Absolutely. That's what we use every day, right? I haven't used analog impression in many, many years, and we like to use technology in the lab as well to design. We gotta get quality digital dental training. I see so many people with so many great equipment there, but they basically know how to use them, right? It would be like me driving a Formula One car, right? It'll be a total waste, right? So I think we need to follow VITA's educational platforms. And as I always tell Jim, it's not only about the webinars. Work is done with our hands still, so we need to do practical hands-on sessions. Use original workflows, and this applies to laminate veneers. I like to use the VITA Accent Plus on top of the Trilux Forte. I like to use their furnace, so that way I'm closing doors of possible problems, okay? And this is not the topic today, but what I wanted to bring out here is that not even in full arch we need analog workflow. So stay tuned. I'm going to have 2 more webinars this year, and we're going to talk in one of these ones about full arch zirconia frameworks and possibilities of digitalization of those impressions as well. So I think it is a very exciting time to be in dentistry. Jim, I want to thank you again for the invitation and the entire VITA North America team. It's been many, many years we've been collaborating and working together, and it's cool to see how some of the things we use are new, as you said, but also some of the things that we use have been out there for many years, right? So it's important to understand indication and contraindications of the materials. We are not from the philosophy of only using one material for everything. We like to have a menu, a practical menu, maybe 2 or 3 options, but with that, we can be specific to each of the patients. So thanks for your time again, and I have time if there are any questions.
All right, Dr. Conejo, thank you very much for those very aesthetic and very smiley cases that you presented. That was great work. Let me go over a few things before we go into the questions. So All right. So you should see my screen there. CE, as I mentioned earlier, we're going to get you your CE, whether it's a letter, whether it's CE brokers or down in Florida, or if it's the NBC, we'll get that information to you. We'll use the registration information you provided us. The webinar was recorded and they are going to be posted here in a few days. So make sure you join us again, and you can review any part of Dr. Conejo's presentation there. Uh, and then let's see here, wrong way. All right. So if you need to get a hold of any of your local VITA reps, there's a list. Dr. Conejo is very gracious to allow you to contact him. Remember, he's in a clinic, whether private or UPenn, quite busy doing traveling, doing all sorts of different lectures and so forth. So give him a few days to respond. We do have additional webinars that are coming up. September 10th is Dr. Conejo's next program webinar. So hopefully you can join us again. But any of these webinars that we're having throughout the rest of the year, you're more than welcome to join us, get some CE, and learn some educated facts about dentistry. I'll update this picture. Got a new one. So I'll certainly do that. But as I mentioned, Dr. Conejo was very gracious to allow you to contact him through email to ask him questions that you might have. So with the questions, one of the first questions we have is, as a technician, how should I prepare my veneer? Should I etch it or leave it to the dentist?
Yeah, that's a great question. I really think that the clinician should be the one doing the etching and silanization of the veneer. And the reason for that is because this veneer is going to go in the patient's mouth for trying. And many times when I'm doing the trying, I might have some blood, I have saliva for sure, I might have some chemicals, right, from let's say the hemostatic agents that I use. So we always like to start cementing from a clean surface. That's why we like to do the trying, take them out, put them on a Ziploc bag in alcohol, ultrasonic bath for 3 minutes, and now we start etching and silanizing, and then we do the adhesive cementation. That way we don't have that variable added, which is the cleaning the contaminated surface. What has been the response to this in the industry? Well, we have ceramic cleaners, right? And those cleaners seem to work, but it's an additional step. So my preference and my suggestion is to have the clinicians do the etching and salinizing after the trying.
All right. Another question is, did you apply porcelain to the Mark II veneers, or was it just monolithic? And if you applied porcelain, what did you use?
Yeah, so actually these three cases are monolithic. We are only using the VITA Accent Plus Stain and Glaze Kit. If you would need to add porcelain, you could use the VITA VM9, and you could also use the newer ceramic system from VITA. Jim, you help me with the name?
Yeah, that it would be Lumex AC, which is
Lumex,
a low
exactly.
temperature
Correct.
using porcelain that we have, a newer one.
Correct. So that would be the Lumex porcelain or the VITA VM9, right? Both have the possibility to be used on feldspathic ceramic blocks. Many years ago, I was doing that more often, and now I really focus more on the design, on the symmetry, on the macro, on the integration between the design of multiple restorations, and just more of external finishing. Is it a contraindication? No, not at all, right? If you feel that you have the case that needs you layer the ceramic because it has a very characteristic incisal third, totally makes sense, right? What is the issue there? Sometimes space distribution, right? So I would like to have those conversations with the technician before we start the case, evaluating what's the starting uh, point, right? And let's say we're doing a veneer only for number 8, and 9 has extreme characterizations, and you need to do internal um, staining and then a little bit of layering of window and all those techniques. Then, if that's the case, that's a great option. But we got to be informed as clinicians as well, so we understand how to prep the tooth to provide you with the needed space. The problem is whenever you try to layer in situations that don't give you the space, at the end, I see many times a better outcome with something monolithic, because space distribution is kind of the difficult point there. Mhm.
Yeah, no, that's a good point. And kind of a couple of interrelated questions we have. One was how thin can you mill your veneer
Yeah,
and get away with it?
yeah. So, there are different milling options, right? With whatever milling system you have. My recommendation with feldspathic ceramics is always go with a fine milling. I never use a fast milling. I don't like to, win time in the milling time. I prefer to be more cautious there. So if you use a fine milling mode, and you have consistency on the thickness, you can go up to zero point 0.4, 0.3 millimeters, right? What do I see? What is complicated whenever you have parts around the margin of 0.3 and the bulk of the veneer at 1 millimeter, for example. But when you have consistency, I see better outcomes. So I don't think that the best technician or best clinician is the one doing the thinnest veneers. It's what the case needs to, but I would say a take home number, a safe number would be 0.5 millimeters. That will help you get out of trouble in many times. And sometimes with very delicate manufacturing and finishing and the use of magnification, I think we can get to zero point 0.3.
And then kind of related, you had mentioned that a certain thickness uh, can influence your shade from the prep.
Yeah, yeah.
Is there a have you found a thickness that occurs
Mhm.
or thinness either way that affects it?
Yeah. So, we've all had a case that we do two centrals, and one looks slightly different color than the other, right? And if you're very critic, if you use a caliper or if you measure on the software, you will see that you have differences on the color, right? Because feldspathic porcelains, that's why they are so nice, because they're pretty much like a glass. They have a high glassy matrix, but also when different thicknesses are present, the light reflection and just the final outcome could be different as well. So you saw the putty matrices, the blue prep guides that I place always to make sure that I have a consistent thickness. But if you have like islands of zero point 0.3 surrounded by thicker areas, in one veneer, and then let's say in the next one you have a homogeneous thickness of 1.0, for example, you can see certain different spots showing through, because they are very translucent and very thin. So the preparation, um, understanding, it's very important by the clinician whenever we're using high translucent materials.
Yeah, very important for the outcome. Uh, the question is, do you change your prep depending on the material? For example, feldspathic versus a lithium disilicate versus a zirconia.
Yeah. So whenever I'm working with ceramics, right, feldspathic ceramics or lithium disilicates, I want to use a chamfer at least, right? I want to use a burr that has a rounded internal um, angle and not necessarily a very heavy shoulder, but I need to have that, let's say, horizontal part of the margin. If I'm working with zirconias, we know that nowadays we can go with a kind of bevel finish line, feather edge finish line. I wouldn't go with that on feldspathic ceramics, and I don't do that on a regular basis as well with lithium disilicates. So those are the things that, let's say, zirconia is advantageous in one way, right? That it could be milled and fabricated even thinner in some specific areas. But I think are different situations. But whenever I'm doing veneers with feldspathic or lithium disilicate, I want to have a nice chamfer, 0.3 millimeter, rounded, and that's my suggestion.
Have you, another question, have you used zirconia for a veneer? And if
Yeah,
so,
yeah,
you,
we have, and to be honest, quite successfully. I published an article last year in the Journal of Cosmetic Dentistry. Actually, was the cover, and it was one of the first versions of ultra translucent zirconia, cubic zirconia with 5% of yttria. And I think that's kind of the indication for that level of translucency in that group of zirconias. When I would use them, well, I would use them when I have patients that want something very bright with a very high value. And sometimes with ceramics, or even worse with lithium disilicates, you can end up with a very kind of like grayish outcome. So for like toilet white cases, those zirconia veneers work pretty good. You gotta work with the MDP containing primers, right? As Dr. Blatz describes the APC, you gotta air abrade the zirconia, apply a primer that has MDP and resin cement. And we'll have time the next two webinars to talk a little bit about that, bonding to zirconia. Jim, I think it's a topic that always comes out. And then you can start using zirconia for those type of partial coverage restorations as well. I think it has an indication. I wouldn't like to abuse from zirconia and just say I'm using it for everything. No, I think that's why we like to have a few options.
all right. Well, I want to thank you for your time, Dr. Caneo. It was, I thought it was great information, great clinical case work, and so forth. Fantastic photography as well. Any last minute comments you want to share with the?
Yeah. Thank you, Jim. I really appreciate that your time as well to always be commenting, and we are able to kind of speak so open, right, of what we like and how we implement it, or at least what works in our hands. Um, I would like to just finish with a comment like I see so many products come out in the market, and I see people so eager to try everything, right? I feel that you're changing so much your material, you never get to a level of perfecting it, of mastering the material. You know me for over 10 years, I think now, and I've been using this material for veneers, and I feel confident, and I know where I can find some issues on, and so that's why I'm not so pro of, changing every month different materials, because you never get time to get that feeling and reach that expertise level.
All right. No, that's good. So I want to thank you for your time. Those registered attending, thank you very much for joining us today, wherever you may be. Again, we have more webinars later this month. Next month, we also have another one with Dr. Caneo, and then we're trying to put one together for Spanish-speaking audience as well. So we'll post that as soon as we get that all together. But I want to thank you again, Dr. Caneo, for taking the time out, sharing with us your knowledge and experience. So thank you very much.
Thank you, Jim. Thanks for joining us. Have a great day, everyone.
Yes, and this will end today's webinar. Thank you for joining us.